So I actually gave a talk on colonialism and neoliberalism and health at a conference in Zurich, and Christian was in the audience, and he said to me, more or less, we were in the bus going home, and he's like, "Yeah, it's worse than you thought. I've been going through the WHO archives, and I found all sorts of things that make what you're saying look even worse." And so we became fast friends. And he subsequently wrote a book about the history of TB. But Christian McMillen, for those of you that don't know him, is a professor in history at the University of Virginia, and he is the author of Discovering Tuberculosis: A Global History, 1900 to the Present, Pandemics: A Very Short Introduction, and Making Indian Law, the Hualapai Land Case and the Birth of Ethno-History. Christian McMillen.
So as Salman said, I'm going to talk in a bit more detail about chemoprophylaxis, IPT, and I've compared it in my paper, my very long written paper, and my somewhat less long presentation to water at the same time in the world of global health, to try and see if some of the things that I wrote about in my book on tuberculosis as they applied to chemoprophylaxis could also be applied to water. Is the same kind of logic working with other things in the world of global health? We know it was working when it came to HIV. And so in the late 1980s and into the mid 1990s, the World Health Organization and the World Bank, among others, but they're the two principal players, reconfigured the global health community's approach to tuberculosis and clean water and sanitation. This is important because approaches to history's deadliest infection, of course, tuberculosis, and humanity's most essential resource have been determined by these two agencies for decades. In the 1990s, 80s, and 90s, debates about how to best approach these problems, and it always seemed to be the case that most felt compelled to pick one approach to each, hinged on cost effectiveness, as you've heard time and time again in the last couple of days. Clean water and adequate sanitation had long been known to be essential, of course, to human health and economic prosperity. But by the 1980s, they came to need financial justification. And this meant measuring their effects. And I'm going to have some slides up that I'm not going to talk much about. But I will draw your attention to a few here and there. This is from March, you can't read the date, but March 22nd, 2017, from the World Bank's water blog. The headline is, "The numbers are in. Water is the key to poverty reduction and health." This is a constant refrain in water and sanitation research, is trying to quantify and trying to audit the connection between water and health to prove it in order to justify interventions in water and sanitation. And what I'm going to try and do is figure out talk about with TB and with water how that came to be the case. TB, on the other hand, by the end of the 1970s, had fallen off the global radar. It was treating and preventing the disease was no longer a global priority as it had been in the 1950s and 60s. That, however, is some of the things Salman addressed. That began to change when several TB specialists, in a series of articles in the early 1990s, demonstrated that directly observed antibiotic treatment, it wasn't called DOTS yet, was effective and crucially cheap. Now, I'm not going to read from any of this. This is one of these seminal articles by Christopher Murray. I thought I had the authors. Christopher Murray, Carl Stieblo, and Annick Rion, demonstrating that TB and announcing for the first time in 1990 that, in fact, it was cost effective. And so it would now be part of selective primary care. Two things, however, thrust directly observed therapy, not yet called DOTS, center stage. In 1993, as Salman said, the WHO declared TB a global health emergency, and the World Bank published Investing in Health, enshrining cost-effective analysis as the method by which health interventions would be judged. Christopher Murray is a name that we've heard several times already, but I'll mention him a little bit more, and we could maybe talk about his role in the questions and answers. But he is a central figure in all this. The author of these series of articles, also the author of the key part portions of the World Development Report from 1993. So by 1993, it became clear that an emergency could be treated. But DOTS, as it came to be known, and as Salman said, ignored entirely both the burgeoning HIV-TB pandemic, which the WHO, as I'll show, had been vigorously working on for some years. And it also ignored, as you now know, multi-drug resistant tuberculosis. A similar logic was at work when it came to water and sanitation, but in a sense that it worked in the opposite direction. Well, TB control was found to be cheap and effective. When it came to reducing disease, providing clean water and adequate sanitation, some, and then eventually many, began to argue was actually ineffective. And it was certainly not cheap. So for decades, quantifying the connection between health and water, most agreed, was, if not pointless, at least exceedingly difficult. By the early 90s, quantification had become essential. Further, while the WHO embraced the World Bank's cost-effective approach when it came to TB and DOTS, because it gave them, in my view, newfound relevancy at a time when their relevancy was quickly waning, the opposite was the case when it came to water and sanitation. The WHO's Environmental Health Division criticized the approach taken in investing in health and found themselves increasingly marginalized in the world of water, routinely left out of global meetings on water, and pleading over and over again to have health be on the agenda of global planning meetings. Now, this was a dramatic turn, this late 80s and early 90s in the world of global health. For a time, as I'll try and show a little bit, from the early 70s to the mid-1980s, the global public health community had a much more expansive vision of what a healthy world looked like. But the pursuit of that vision of health and justice in the 70s and into the 80s was lost by the end of that decade, really just fogged in by this haze of cost-effective analysis. So as I began to, I'm going to focus on water first for a little bit and then tuberculosis. And so as I began to explore the history of water and sanitation, one of the questions, as I said, that researchers came back to again and again and again is how to prove that there's a link between providing clean water and sanitation. How can it be shown? How can it be quantified? And it turned out that this question had been around for decades. It's not a new one in 2017. In 1990, for example, or in the late 80s and early 90s, I kept finding comments in articles and archival sources like the following. This is 1990. Hiroshi Nakajima, who was then the director of the WHO, gave a speech in New Delhi at a conference called The Plan for the 1990s. And towards the end of his remarks, he said, in summary, strategies for the 1990s are not limited by any profound mysteries, masking the linkages between water and sanitation services on the one hand and health on the other. Among other, as I said, many, many other sources, I wondered what was going on. Why was anyone questioning this link? Why did the Director General need to address it? This is a major meeting in Delhi to plan for the entire decade of the 90s. And he's compelled in his concluding remarks to the whole conference to address this mysterious link between health and water. And also, I'll try and sketch out a tentative answer. These are just a couple of the other articles that Steve Lowe or Murray and colleagues authored. This is also from March. It's now time for a radical investment in water and sanitation investment in 2017. I mean, there's so much cynicism floating around in the room, but it's hard. It's hard to get away from. So yeah, this is the headline in March of 2017. Water is the key to health, and it's now time to radically invest in that. So until the late 80s and 90s, as I said, it was a given that there was a link between clean water and good health. And most considered the development of clean water supply to be a cornerstone of economic development. This had been a standard refrain since the middle of the 19th century. Finding evidence of any sort of controversy is nearly, if not actually, impossible. By the early 1960s, when the WHO, who was then the major player in global health, this world of NGOs that we live in now simply didn't exist, WHO did almost everything and determined trajectories all across the world. They began a period of sustained interest in water supply, sanitation, and environmental health. To them, to workers at the WHO, the connection between clean water and good health was not questioned. In 1962, in a report by the Southeast Asian Regional Office called The Role of Health Services in the Improvement of Community Water Supplies, the author wrote the following, I think, fantastic quote. "It is scarcely necessary to detail the relationship of water to public health. Statistics are abundantly available to prove every point, but statistics are not really needed. An astronomer can, if pressed, give detailed figures on the decrease of luminosity, which marks the passage of the sun below the horizon. But the least educated human knows that when the sun sets, it gets dark. So it is with water and health. It was obvious. The connections between health and water were self-evident, and so too was the link between water and economic development. In 1963, the WHO produced a massive report called Urban Water Supply Conditions and Needs in 75 developing countries. It was written by its top 2 sanitary engineers. These slides are just demonstrating that people have known that clean water since the 19th century was really essential to health. We didn't need to wait till the spring of this year for the numbers to come in. Even children knew about the relationship between cholera and water. Both were acolytes of development economist Albert Hirschman. Paraphrasing and citing Hirschman, they wrote in this WHO report regarding water projects that it is recognized that in any economy, a substantial proportion of funds must be devoted to projects whose output has no readily assignable or fully recoverable market value. The following year, and I'm not, I promise, marching year by year, when about to launch the Community Water Supply Program, the Director General of the WHO took this message to the World Health Assembly, saying that although it is difficult to establish a quantitative relationship between, say, the extent to which piped water is supplied to urban settlements and the rate of economic growth, economists agree that without sound urban conditions, no lasting economic development can take place. And so both the bank and the WHO ended the 60s and began the 1970s committed to water and sanitation development. They entered into a formal agreement in 1972. As their work began to intensify, however, some at the bank began to wonder about the connection between health and clean water. Was there a demonstrable, quantifiable link? In 1975, the bank commissioned a high-level review panel to, quote, deal with the problem of predicting and quantifying the impact of improved water supply and sanitation on public health. The panel's report concluded, it is extremely difficult to identify and measure exactly the health benefits of an improved water supply, and there is a limit to the precision attainable. The difficulty of quantification did not dissuade the bank from investing in water projects, deciding that, quote, it should be sufficient to accept, and they emphasize this in the original text, the universally recognized fact that the provision of an adequate supply of safe water is a basic necessity for the maintenance of good health and productivity. When thinking about the myriad diseases that might result from inadequate sanitation and dirty drinking water, the author, who is a physician, by the way, of tropical medicine, not an economist, of the report the bank relied upon, noted dryly, I do not know how to reduce many of these diseases to economic terms. So as a result of this commitment, as a result of accepting this universal fact, the mid to late 1970s was a very productive time in the world of water development. Tens of thousands of pumps were installed all over India. The bank refinanced the construction of many, many, many cities in the developing world's water infrastructure and so forth. But by the decade's end, many believed that, in fact, not enough was being done to deal with the problem of bad water. In 1977, the UN convened the first global water conference in Argentina. And out of that meeting, and based on the previous decade's experience, the bank, the WHO, and UNDP, all the major players, the UN system, and delegates from 24 different countries committed themselves to launching, funding, and carrying out what came to be known as the International Drinking Water Supply and Sanitation Decade. The decade's goal was extraordinarily ambitious: provide drinking water, 2 billion people rather, with clean water and adequate sanitation. And never had the needs of the developing world, the water needs of the developing world, ever been taken so seriously and acted upon so vigorously. During the course of the decade, an estimated about 1.2 billion people were actually provided with adequate water supply, and 770 million, about 3/4 billion, were provided with access to sanitation. But population growth and so forth, movement to cities, mitigated some of the effects, and some began to critique the decade's approach. It was too one-size-fits-all, not flexible enough. Governments weren't showing enough commitment and so forth, maintenance problems, and on and on. Also growing was the bank's concern that the undisciplined and potentially inefficient use of resources during the water decade needed to be addressed. These are just examples from the early 90s of various, World Bank and so reports having to justify the connection to water and health. Deborah Blum and Richard Feacham, two prominent figures in the world of water development, warned in 1983 that, quote, while the international drinking water supply and sanitation decade may carry a momentum of its own, unless it can be shown that such improvements confer some benefits, either in time savings or improved health, there may be a backlash against large resource allocations once the decade is over. And then, halfway through the decade, and only 10 years after declaring in 1975 that, quote, the most important benefit from improving the quality and quantity of village water supplies is the improvement in public health, the bank began to have a change of heart. Before the decade was half over, in 1985, the bank began a comprehensive rethinking of their role in water development. This, of course, is all predating the World Development Report. The World Development Report, I think most would agree, is really both the announcement, the culmination of this way of thinking, and its kind of public debut. But the bank has been developing this way of thinking for some time. They began to rethink their role in water development. Rural water supply and sanitation, a framework for improving investments, typically banal-sounding internal document, was this first clear sign, and it's one of a series of 3 very important reports written critically by economists, not epidemiologists, not public health specialists, not water and sanitation workers. Inspired by what the bank perceived to be the lackluster performance of the decade, the document declared that an examination of the problems of the decade indicates that there is a need to change the way in which resources in this sector, the water sector, are allocated and utilized. Too many untested assumptions have been made about both the costs and the benefits of these investments. The decade became clearly the major catalyst for rethinking water. The narrative of failure that was being written really by the World Bank, was what generated a rethinking of water. For too long, the bank and others had been investing in water projects without knowing their actual value, nor giving adequate thought to how projects would be financed. Until now, quote, most investments have assumed 2 critical propositions. One is that rural households are unwilling or unable to pay for improved services. This would become a major focus of World Bank research, and I know people are going to talk about user fees later. The assumption that people won't pay for water needed to be questioned. The bank determined, in fact, they are willing to pay for water, and that leads to all sorts of problems. The other assumption is that water supply and sanitation improvements will have significant health benefits for the population affected. Taken together, these assumptions have led planners to justify water supply and sanitation projects as necessary for general health and welfare rather than in terms of standard benefit cost criteria. Now, I've read that quote many, many times. I've wondered what, taken together, these assumptions led planners to justify water supply and sanitation projects as necessary for general health and welfare. I'm still unclear on what other justification might be necessary. In any case, when evaluating water investments in 1987, 2 years later, a bank economist wondered, in rural water supply and sanitation, time for a change, do rural water and sanitation projects have significant health benefits? The declaration of the International Drinking Water Supply and Sanitation Decade and the formulation of current rural water supply and sanitation strategies are predicated on the assumption that the use of improved facilities will lead to substantial improvements in health. However, efforts to demonstrate that projects and policies do indeed have health benefits have not always succeeded. So 10 years after declaring there's a limit to precision attainable, the bank is unsatisfied now with that answer, and they're really rethinking their fundamental commitment to water. Now, a year later, finally, in the these are the assumptions, the untested assumptions. A year later, in the final, in this sort of trio of internal reports, two economists at the bank made the following claim, and you've heard. I heard someone groan when they saw one of those names anyway. Until comparatively recently, the aid community has been sharply divided on rural water strategy. To simplify a complex debate, some institutions have argued that the financial viability of the sector must be a primary concern, while others have maintained that the highest priority should be the rapid expansion of services to meet the basic needs of large populations. That was how this debate is characterized. And published in 1988, Water for Rural Communities, Helping Poor People Help Themselves, the last in this series of bank publications, advocating new financing models in the provision of clean water and health. The claim, however, that, quote, the aid community has been sharply divided implied that the sharp divide they referred to was a long-standing one. But that's not the case. In fact, it was quite recent and only seems to have become a significant concern when the bank decided to rethink water finance. In other words, the bank became the other side of the debate. So why did this debate emerge when it did? Or perhaps why was it created or manufactured when it was? Why did the bank begin to wonder if water and health were related? Now, people have referred to this period of, the writing of the World Development Report and so forth, and I'm not going to go into much detail on this, on the explanation or how that came about. But, I will just say and reemphasize that the late 80s and early 90s were this time of really monumental, critical change in the world of global health. When it came to water, the end of the decade, the water decade, and not being able to realize the ambition of providing clean water for all by 1990 tempered enthusiasm and caused the bank to create this narrative of failure. And with the publication of their World Development Report in 1993, the balance of power in the world of global health shifted, as many of you know, decisively and definitively towards the World Bank. Shortly after publication, The Lancet declared, investing in health marks a shift in leadership on international health from the World Health Organization to the World Bank. The implications of this were many, but most profoundly, and this goes for TB as well, as you'll see, health interventions would be undertaken, as Salman said, only after they had been deemed cost-effective in this novel way introduced in investing in health. Interventions would be considered cost-effective based on what were and are called disability-adjusted life years. Now, if a given intervention was expensive relative to other interventions and did not necessarily save many lives, it was, of course, not cost-effective. TB, by this point, almost by this point, has been found, well, actually, of course, by the World Development Report, has been found to be cost-effective. So inexpensive treatments, such as antibiotics for TB and very critically for oral rehydration therapy for diarrhea, did save many lives, were cheap, and thus they were cost-effective. Water and sanitation works, since they can be exceptionally expensive, in fact, they almost always are, and because they don't necessarily have demonstrable, quantifiable benefits, might not be considered cost-effective. But it was, of course, the very same people creating the doubt surrounding the link between clean water and sanitation. It was the very same people that were also deciding things based on cost-effective analysis. Not everyone, however, was happy with what was going on with cost-effective analysis and water. When critiquing drafts of investing in health, many at the WHO, who had been invited to collaborate with the bank, were alarmed by the focus on cost-effective analysis. One comment noted that, quote, equity and cost-effectiveness are not always compatible, and this should be explicitly discussed. Another comment put it bluntly, under the logic of cost-effectiveness, there are no privileged population groups, only privileged interventions. Focusing only on inexpensive treatments, of course, meant that the root of a given problem went unaddressed. Reflecting on this point, the director of the WHO's Division of Environmental Health offered his comments to the director of the bank's team working on investing in health. And this is all in letters and memos and so forth in the archives in Geneva. It should be stressed that the basic environmental threats, water, sanitation, shelter, etc., have only been reduced in developed, and he stressed the word developed, countries after enormous, stressing enormous, investments in drinking water supply, sewage treatment, etc., with enormous recurrent costs. These costs in developing countries are, of course, highly justified and essential to protect health, but they seem to be universally forgotten in texts of this type, referring, of course, to the drafting of the World Development Report. Needless to say, none of these critiques made their way into the World Development Report, and virtually nothing the WHO did at the time to critique other elements of the World Development Report made it into the final draft. They were just, more or less blatantly ignored. Focusing too much on curative services and not at all on prevention, which is effectively what this is advocating, struck the Director of Environmental Health as, quote, an ambulance at the bottom of the cliff approach. To some, this was just what was happening in water work. As early as the late 1970s, health economists began to argue, and you're going to know who those two health economists are before I tell you, Kenneth Warren and Julia Walsh in Selective Primary Healthcare, you've seen that slide many times, began to argue that oral rehydration therapy and not developing water and sanitation services was the cost-effective approach to the problem of bad water. But to some, providing ORT, oral rehydration therapy, instead of an adequate supply of clean water was a perfect illustration of placing the ambulance at the bottom of the cliff. Indeed, in 1987, an internal USAID report, The Value of Water Supply and Sanitation and Development, an assessment of health-related interventions, recognized this. What is not so readily demonstrated is why ORT has been perceived as being the program of choice, replacing other options, and particularly water supply and sanitation. The life that might be saved by ORT is only saved until the next attack of diarrhea. The, quote, saved child may need to be, quote, the quotes are in the original, saved again and again, unless and until the environment for the child is improved. ORT is not an investment in future public health. To be effective, ORT must be administered ad infinitum unless other interventions are introduced. This, you can't, you've seen this several times already, the Selective Primary Healthcare. This is just a document, not deeply important, from WHO, talking about the need, and this is in 1966, to they're unwilling any longer to support specific interventions for diseases like cholera. As ORT is becoming more and more tested, more and more known, that investing in sanitation services, water and sanitation services, is the way to go, and that is the direction they are heading in, and that is what they want to do. A decade later, a little more than a decade later, is the beginning of the end of that approach. By the early 1990s, that approach has died altogether. And so by the end of the 1980s and into the early 1990s, no longer was it the case that water projects were self-evident. The value, rather, of water projects was self-evident, having no need to be justified. This, of course, as I said, was a dramatic turn in the world of global health. At the same time as this is all occurring in global health, more or less the same logic with different results is being applied to tuberculosis. Now, Salman's already detailed what isoniazid prophylaxis therapy is. I'm going to talk a little bit about how it was framed as a problem, and then how it was revived, and then how it was killed again. But I won't talk about how it was then revived again. I'm going to talk about two of its deaths and one of its rebirths. By the early 1960s, as Salman said, IPT was well known to be an effective intervention, had been tested in many, many, many places. There was no doubt as to the science behind it. But as early as 1960, despite it having, quote, been definitely established as effective, this is the WHO, IPT in Africa, according to the WHO, faced insurmountable obstacles. And the WHO, while they declared in 1963 that determining whether or not IPT worked was a, quote, urgent research priority, the following year, without ever actually testing its efficacy, the WHO's Expert Committee on Tuberculosis discouraged its use on a large scale, arguing that cost, logistical difficulties, the likelihood of defaulting, and other concerns made it unfeasible. And these would be the arguments that would be used again and again and again. When the expert committee met again and issued its next report in 1974, They considered the use of isoniazid preventive therapy to be, quote, irrational. In 1982, citing fears that its implementation might take resources away from curative treatment, this would also become a common refrain. The WHO and the International Union declared that, quote, in practice, IPT has virtually no role in developing countries. The IPT by the early 1980s then appeared to be dead. But then HIV changed everything in more ways than one. Within less than a decade, IPT went from having virtually no role in TB control to become again one of the WHO's research priorities. It became vitally important to many to know if IPT would work amongst HIV-positive people. And just as importantly, could IPT work on a scale necessary to control the TB-HIV epidemic in places where the co-infection was exploding? The latter question in these early years especially was never adequately answered. In 1989, Jonathan Mann, who was then the director of the WHO's Global Program on AIDS and would soon not any longer be the director, wrote that delaying or preventing TB may be the single most important thing that can be done in developing countries for prolonging the survival of HIV-infected persons. By 1989, in fact, the WHO and the Union had decided that testing the efficacy of IPT was an urgent priority. That same year, the WHO convened a group of TB and HIV experts who were, at that point, working together much more than they ever have since, and recommended that the WHO should vigorously promote studies of tuberculosis chemoprophylaxis in HIV-infected persons as a major priority for research. Almost immediately, the WHO sponsored IPT trials in Haiti, Zambia, Uganda, and Thailand. What was once irrational had now become essential. In 1992, the top TB people at WHO declared that in view of the high risk of tuberculosis in duly infected persons, prevention of tuberculosis in such persons is clearly a high priority. Administration of preventive chemotherapy to HIV tuberculosis co-infected persons has therefore been considered as one of the most critical interventions to limit the increase in clinical tuberculosis that is expected from the pool of HIV tuberculosis co-infected individuals. Some of these quotes I realize are a mouthful. After successful trials in the early 90s, 3 prominent researchers confidently claimed in The Lancet in 1995 that for the HIV-infected individual in Africa or Asia, preventive therapy for tuberculosis may represent the single most useful intervention for the prolongation of healthy life. But the challenges, according to eventually the WHO, thrown up by poor compliance and adherence were daunting. And when studying feasibility and cost effectiveness, the difficulty of surmounting the challenges of everyday lives doomed IPT. Instead of shifting, or rather identifying barriers, embarking on a research strategy to try and figure out how to improve adherence, and then devoting the resources to implement such a program, it was easier to simply give up. Rather, a convenient shorthand emerged in almost all the literature. The African context was deployed. And in that context, IPT was deemed not to be able to work. AIDS, the journal AIDS published a discouraging feasibility study in 1995, not enough data, too many barriers, too many patients lost, that really seemed to signal the end of IPT. And by then, cost-effective solutions were absolutely essential. And just as IPT research was getting off the ground in the early 1990s, one such solution seems to have been found: directly observed therapy. As isoniazid prophylaxis therapy was still being studied, the World Health Organization announced a new direction. Debuted in their framework for effective tuberculosis control, quote, the revised strategy adopted by the WHO is simple. All countries with a TB problem must provide standardized short-course chemotherapy to at least all sputum smear positive patients. The revised strategy did not include IPT. Rather, in boldface, the WHO declared cure is the best prevention. Soon to be packaged, as we all know, as DOTS, this new strategy was for a decade hailed as the magic bullet. The simple act of watching people patients take their medicine would ensure success. And Salman went through all the other reasons why it hasn't been as effective as was hoped. DOTS ignored HIV also. The WHO claimed that once the new framework was in place, quote, systems to monitor HIV seroprevalence and drug resistance in TB should be added. They never were. While IPT studies were well underway and the WHO was seemingly committed to chemoprophylaxis, the TB program, the Global Program on AIDS, which Jonathan Mann had now left, and the International Union Against Tuberculosis published a joint statement on IPT in 1993. The statement read in part, "There is sufficient information to support the recommendation of isoniazid therapy for tuberculosis infections." But hovering up above that reference was a footnote, which read, "However, isoniazid preventive therapy is not recommended for implementation as one of the components of the tuberculosis control strategy in program settings worldwide." It went on to say, "Program implementation of preventive therapy would only be considered in areas where tuberculosis programs are achieving global targets established by none other than the WHO." The none other is not in there. I.e., successfully treating 85% of detected smear-positive cases and detecting 70% of existing new smear-positive cases, neither of which were detecting new cases was not part of DOTS, and where voluntary testing and counseling for HIV infection is available. This will also require close collaboration between national AIDS and tuberculosis control programs, which is to say, of course, virtually nowhere in the developing world. Thus, the beginning of the end. In the context of cost effectiveness, IPT never had a chance. Chemoprophylaxis might have had a place in TB control among high-risk groups like those living with HIV, still apparently just a high-risk group and not a massive portion of the population. But as a research group including Murray and Stiblo wrote in 1994, case finding and chemotherapy for smear-positive pulmonary tuberculosis is the mainstay of control strategies. Stiblo, who had never been a fan, had come out against IPT several years earlier. Despite claiming that, quote, "there is no doubt that adequate chemoprophylaxis could significantly decrease the occurrence of tuberculosis caused by HIV infection," he nonetheless cited IPT's cost, logistical difficulties, and worries over patient compliance as reasons for not even trying. Once cost effectiveness became the benchmark by which all efforts had to be evaluated, then it appears to become the case that only the one most cost-effective control measure would be pursued. There was no room for both DOTS and IPT, just like there was no room for water supply and sanitation and oral rehydration therapy. DOTS was considered to be more cost-effective, so DOTS it was. Of course, it's not as if the bank or the World Health Organization or anyone else really said to the world, it's either DOTS or IPT, you can't have both. But that's really effectively what happened. DOTS was found to be cost-effective, though its efficacy was not well understood, and so it gained supremacy. IPT, though without ever thoroughly being studied, was found to be not cost-effective. Now, almost done. While of course related, DOTS and IPT are not simply two alternatives to the same problem. They should never have been examined side by side as if they were, just as water supply and sanitation and oral rehydration therapy should never have been considered as two alternatives to the same problem. Yet at a 1995 WHO meeting on the TB-HIV epidemic, Christopher Murray effectively did just that. Murray reported that modeling had suggested that, quote, "IPT is a very cost-effective intervention in HIV-infected individuals." And he goes on to cite statistics on how much TB it will reduce. But then he went on to say in the next sentence that, quote, "short-course chemotherapy is about 4 times more cost-effective." Now, it's of course certainly possible that those at that meeting could and did tease all this apart. Still, it's hard to see how most would have heard Murray saying two separate things. First, IPT is a cost-effective intervention for its intended benefit, preventing TB in those who are HIV positive, among others. And second, that short-course chemotherapy is a cost-effective intervention for its intended target, treating those with active drug-susceptible TB. Rather, it's more likely that most left that meeting thinking nothing more than that treatment was the most effective TB intervention, cost-effective, that IPT was 4 times as expensive, and so to control TB, treatment was the way to go. Recall the WHO official earlier saying there are no privileged populations, only privileged interventions. When the WHO and UNAIDS revisited the question of IPT in 1998, it became clear that DOTS and IPT were being considered as two alternatives to the same problem. The evidence shows that IPT is, quoting, "is not an alternative to the DOTS strategy for controlling TB, even in areas with a high prevalence of HIV. A clear statement of the comparison or putting them side by side can't be found, though it was followed by the jarring lament. Many opportunities for providing PT to people with HIV have been missed, and this has led to many cases of TB that could have been prevented. Without an endorsement or funding, however, from the major players, WHO, the World Bank, the Union, UNAIDS, all of whom by this point had abandoned IPT, was it any wonder that many opportunities to use IPT and thus prevent TB have been squandered? Well, it's a surprising statement, of course, because of who delivered it, the very entity that was in fact ensuring that many more opportunities would be lost. And if you want to know even more about this, you can read my book, where it's detailed much more